Hi, folks. It's still a couple minutes before 7 o'clock, and so we're just going to wait a little bit and then let everybody get signed in. And welcome to this webinar. Looking forward to having you. Okay, folks, it's 7 o'clock. We're just waiting for a couple more people to come on board. Welcome to our webinar on innovations in senior telehealth. And we'll give it about one more minute and then we'll get officially started. Okay, let's get going. Welcome everybody. My name is Rob Ray. I'm the CEO of Blue Star Telehealth, and welcome to a 30-minute webinar on innovations in senior health. And we sent out a invitation earlier, and we have a group of folks on board. If you have questions, please type them into the question box, and I'm going to plow through a lot of PowerPoint in the first 15 or 20 minutes, and then there'll be an opportunity to answer questions. So the very first thing I'm going to do is to share my screen and bring up a PowerPoint for you. Okay, innovations in senior telehealth. Today we're going to talk about 5 things. First, a quick update on the CMS Medicare telehealth mandate. We'll talk very briefly about 5 years of senior tech in the home, new rules on remote patient monitoring. We'll talk about pros and cons, both for the patient and for your practice, and then how to make it happen. Again, my name is Rob Ray. I'm a retired Navy Admiral. I'm a nuclear engineer, and I'm the CEO of Blue Star Senior Tech. Blue Star Senior Tech has been providing equipment in the homes of seniors for 6 years. Something like 20,000 family years of services across America, with about 5,000 current customers across all 50 states. And I'm also the CEO of Blue Star Telehealth, which focuses on remote patient monitoring. So the things I'm talking about are things that we've been doing for years. All right, first, telehealth. Telehealth is the future of care. I won't go into it in too much detail, but 83% of Americans are ready to use telehealth. 70% of them said that technology would encourage them to use it more if the technology were simpler. 60% of Americans said, hey, I'd use it more if my doctor told me to use it. And 60% of seniors were also willing to use it to support their chronic conditions if their doctor advised them to do it. It's a huge part of the healthcare market, and it's growing by leaps and bounds every day. And interestingly, 50 million Americans said that they'd be willing to switch medical providers if it could increase their opportunity for telehealth. That's how much they're interested. So back to our 5 steps of the table of contents. CMS is pushing the world towards telehealth. They can't mandate it, but it can drive towards it. And it's doing that for four main reasons. Number one, telehealth can lower costs across the system, across the entire healthcare system. Number two, it provides greater access, which is a huge governmental imperative, is to provide access to people in rural areas, but also people who are transportation limited and can't get to the doctor as easily. There's a shortage of physicians and it's getting worse. It's projected that in 10 years, we're going to be short 100,000 physicians. Telehealth can help to compensate for that shortage. And lastly, with the boomers graduating into the senior population and the senior population growing faster than any other segment of the country, increasingly, there's a mismatch in the ratio between the number of seniors that need care and support and the number of working people that are providing it. CMS has three levers to move in this mandate direction. Number one, it can adjust reimbursement schedules, which it is doing furiously. Number two, it can implement the merit-based incentive payment program, MIPS scores, in which doctors are financially compensated and financially rewarded for reducing cost, improving quality, improving IT interoperability, and for engaging patients. And then number three, CMS and other government organizations can educate the patient and the provider that telehealth is a good thing. Now, in the next 3 minutes, I'm going to go very rapidly through non-healthcare senior technology, because the name of the webinar is about senior technology innovations, and this is the non-healthcare side. It's growing very rapidly on the commercial side because seniors are growing rapidly. Seniors are increasingly tech savvy. Smartphones are getting smarter, and a greater percentage of the senior population is getting smartphones. Wi-Fi is good and solid and ubiquitous now. The wearables, we don't even need to talk about that. And then the Internet of Things, which is growing at 50% annually. All those are driving senior tech in three categories: in safety, health, and connection. And now, I'm not going to make you smart in this. I'm just going to skim over the wave tops so that you'll know that it exists. First, there's the famous in-home medical alerts. These are the help I've fallen and I can't get up buttons. Everybody knows about them. 3 million of our 45 million seniors in America have a medical alert device. Then there's mobile medical alerts, and the mobile medical alerts are getting more and more sophisticated. They've been around now for almost 20 years, and they are getting smarter and smarter. Fall detection, GPS location. They're more than just the ability to press the button when you're away from the house. Now people can find you and do other things. Then there are hybrids, which are medical alerts that are part in-home and part mobile. There are medical alert watches, in which they're trying to put the functionality of a medical alert into a watch. And there's a bunch of them, and there are more. I just chose not to put them all on this page. Now there's medical alerts via voice, where there is no technology that you have to wear, no buttons around your neck. You just use your voice to call for help. And as you know, Alexa and Echoes and that whole world is coming fast to a room near you. We include, as part of safety, kitchen fire prevention, because seniors disproportionately burn down the kitchen when they leave the oven on or the stove on and forget that there are things in there. Or, as happened in my family, my mother-in-law, when she got into her 90s, started to put things into the oven that shouldn't be put in the oven, and they would catch on fire. Lastly, there's personal alarms, lots of different things that are not medical alerts. They either make noise or they call friends when you need help. When it comes to health, there's remote patient monitoring. This is not through a doctor. This is just within the family. The family can buy a system and manage mom's blood pressure with an adult daughter. There's activity monitoring. We can tell how many times, if you want, people go to the bathroom, or how many times they get out of bed, or how many times they open the door to the backyard. There are all kinds of health watches that Fitbit started, and now there's 20 other different ways to measure health, including the Apple Watch, and Samsung has a sophisticated watch. Prescription management is senior technology in the home. 2 out of 3 seniors, the pill that's being taken is at the wrong time or by the wrong senior or the wrong medicine. So there's lots of different technologies to manage prescriptions. And then there's miscellaneous things, pillows that help people fall asleep, that have electronics inside them and brain fitness and exercise. The last thing, safety, health, and connection, is connection. It's very important, obviously, senior isolation, et cetera. So there are different computers out there that are designed for seniors. There's a bunch of different phones, both cell phones and non-cell phones, that are designed for seniors so that they can hear better or so that they can see better. There's new hearing technologies out there that didn't exist before. The government is reducing its regulations for hearing aids, and those reduced regulations are driving the cost down, in some cases by 90%. And then connection and companionship. Everybody wants to have a pet at home when they're alone and lonely, and there are robotic pets that can induce the same physiological responses in a senior that a real pet can do. And lastly, things like GoGo Grandparent, which is effectively a Lyft or an Uber for seniors, checkup calls, calling seniors and talking to them, reminders with the voices of their adult children, shoes that let us know when mom leaves the house if she's wandering. All these are miscellaneous connection items. And lastly, video. And I don't need to tell you about Facebook and the Echo Show and the Google and all the different videos, but there's nothing more important to a senior who is living alone than to be able to talk to his or her grandchildren and family members via video. Okay, and then there are integrated systems that one can get. All right, so that was a quick overview of senior technology, and I told you it'd be quick, but I just wanted to give you a sense of what's out there, because we find that many people don't know about that. Even people who have seniors as parents aren't aware of the plethora of materials and products that are out there. Okay, item 3 on our 5-item list is we have this rapid walk through senior telehealth. There are new rules on the RPM, on remote patient monitoring. So every year, CMS comes out with a Medicare physician fee schedule, and it has rules and policies, and it has lots and lots of numbers. And in December, CMS came out with their new rules for telehealth and virtual care for calendar year 2021, which is what we're in. And changes and updates, they changed and updated the Medicare telehealth list. They essentially put a lot more things in there. There is a list, if you go to CMS and just Google Medicare physician fee schedule, then the famous MPFS, you can find the link to the telehealth list and click on it, and it'll tell you all the things that are reimbursable under this fee schedule in telehealth. But they added a bunch of things, including new forms of behavioral health, care planning, new forms of home visits, discharge day management, psychological testing, therapy, all kinds of other services. They clarified their rules to allow virtual check-ins of patients. You know how when you are an actual patient in an actual doctor's office, you got to walk in and fill out some forms and see the lady at the front desk. Well, that can be done virtually now via phone only, and there's reimbursements for that. It made some of the COVID rules that were temporary before, it made them permanent. It clarified what is a medical device, and it has to be FDA approved, and that RPM data has to be automatically collected. You can't have someone take their temperature and then either call in or go onto a website and type it in. That doesn't count for RPM. The temperature measuring device has to automatically send that information to a database that is connected to the doctor's office. It had clarification on how the 20 minutes in the monitoring code had to be spent. It clarified that RPM can be used for acute conditions as well as chronic conditions. It clarified that certain smartphones that can do video and audio can be used for telehealth and be used for RPM reimbursement. And then it talked about electronic prescriptions of controlled substances. This isn't an exhaustive list. These are the highlights. Again, if you want to know exactly what the rule changes were, then Google it. But you really got to know not only the changes, but what the rules were before. RPM has 5 steps. And I'm just going to go through them now. I'm a big proponent of doing anything I can do on 5 fingers, and it's the same way with RPM. First of all, the provider prescribes. The doctor or a clinical provider in the practice sees a patient or knows a patient or has a patient, and they see them either in the office or via video or through some telehealth encounter, and they decide Mrs. Smith has hypertension, she's had a problem with keeping her medication appropriately regulated, and therefore her blood pressure has been all over the block. We're going to prescribe RPM for her. You have to get patient consent to do that. Step 2, activation. Someone has to assemble the equipment and then program it and then ship it to Mrs. Smith. Then we train Mrs. Smith in its use. And then CMS reimburses for that with CPT code 99453. Across the country, the average reimbursement for that is about $19. The next step is ongoing operation. Now there's hardware in Mrs. Smith's home. There's software that's taking the data and transmitting it through the cloud to the nursing staff and to the providers. There's communications to make all that communication work. There's tech support. CMS reimburses that at about $62 a month on average across the country with CPT code 99454, which can be billed monthly every 30 days. The next step, someone has to look at the data and engage with that patient. So the practice can use its own staff. They have to be qualified healthcare providers, or you can outsource that to a third party like Blue Star or someone else. And that's nurse interaction with the patient to look at the data, to make sure the patient's doing things correctly, and to keep the patient engaged, because the patient has to keep doing this or the system falls apart. The first 20 minutes of that data review and patient engagement is billed through CPT code 99457, which is about $52 on average across the country. And then for additional work from that nursing team working with that patient for a second or a third 20 minutes, one can bill a different code, which is 99458, which is a slightly less amount of about $42 a month. And finally, if Mrs. Smith's blood pressure has issues or if she needs follow-up, then the provider follows up. And the provider interacts with Mrs. Smith, and it can be a telehealth engagement, and then it would be billed under whatever CPT code for the telehealth engagement is appropriate. And depending on how much telehealth the provider does with Mrs. Smith, then over the course of a year, the reimbursement for that level of telehealth can be anywhere from $60 to $100 monthly. So we're on a tight schedule, but those are essentially the 5 steps of RPM. And if I left anything out or if you have questions, we can go through them at the end. So we're on step 3 of 5. Number 4, pros and cons. For the patient, the pros start with greater convenience. I said earlier that 50 million Americans said, I like the convenience. 83% they were ready to use telehealth because frankly, it can be a lot easier seeing the doctor via a computer or via a smartphone than driving to the doctor's office. For the patient, it also can mean more frequent interaction, particularly if a nurse corps or the qualified healthcare professionals can interact with the patient a lot more often than the doctor can. It means that new forms of care are available. There's other modalities of taking care of your chronic conditions than just going to see the doctor once a quarter. My mother-in-law had, in her 90s, had terrible hypertension, and she'd go see the doctor once a quarter and get her blood pressure taken once a quarter, and the doctor would talk about her medicine once a quarter, and that was basically it. And the doctor had to do all his evaluation based on those 10 minutes of seeing her in the office and that one blood pressure. There can be greater outcomes through greater engagement, and there's ample evidence, particularly in hypertension, to show that daily monitoring and daily interaction with the clinical care team increases the rate at which blood pressure problems can be gotten under control. It almost doubles it. In a group of 100 people, a group of 100 people with hypertension, 50 of them typically have it under control. But with a regimen like this, that 50 number goes to 90, which can be life-changing. And then some people, particularly in these COVID times, don't like going to doctor's offices because they feel like they're contagious. And if you can see the doctor in the comfort of your home, it can be safer. Now, the cons for a patient, some patients miss seeing their doctor face-to-face, and I don't blame them, okay? Not all issues are well treated through telehealth. Sometimes, obviously, a doctor has to touch a patient or to put a stethoscope or an otoscope or anything else that involves actual interaction face-to-face with the patient. And then some patients, particularly older patients, have some problems with technology. So not all things are rosy for the patient. For the practice, the pros involve flexibility in delivery. We have some doctors now, and in fact, I know a doctor who swore that he was never going to go near telehealth, and now he doesn't go into the office on Fridays. He does all his telehealth from home on Fridays. And he sees just as many patients as he did when he went to the office. There's a potential for increased revenues, absolutely. There's potential for better outcomes, and better outcomes for patients equal better outcomes for doctors and for providers. And then one can get higher MIPS scores, which also has financial incentive. For cons, again, some doctors miss the inpatient approach or the inpatient interaction, particularly if you have to touch that patient and to do things that you just can't do through RPM. Some staffs, well, all staffs, don't like change. They don't like new processes. And some of that is involved in RPM, although not too much. And then there's some logistic and labor issues. If you're going to do the monitoring in your practice, then you have to devote the labor to do that and train that person. If you're going to ship and assemble and inventory and program the equipment, that's a non-zero task. And so you'll have to make adjustments for that. Now, how to make it happen, and then we'll get to questions. I broke my 5-finger rule here, and I have 6 points. 1, begin with the end in mind, as Stephen Covey says. What are you trying to accomplish? What's the goal here? Okay, figure that out first. Number 2, get smart, read. There's the telehealth.hhs, which is the Health and Human Services site for telehealth, is very good, very informative. AMA has a digital health implementation playbook. It's about 100 pages, okay? And it's available to anybody. I think a lot of it is kind of motherhood and apple pie, but there's some good checklists in there, and it does a good job of saying, okay, so you're thinking about RPM, here's how you might do it. After you've done the reading and determined your game plan, talk with an attorney, make sure that your insurance coverage is okay. Talk with an attorney if you have any questions. There's a number of telehealth attorneys across the country now, attorney firms that focus on this area. If you need one, happy to introduce you to ours, which we find is increasingly happening in the industry. If you have questions about RPM or you want to talk about how you might be able to implement it in your practice, we'd be happy to provide free consultation, happy to answer your questions, happy to shoot the breeze. We won't be selling stuff. We'll just be trying to explain stuff because that's what we do. And then talk to others. There are probably other practices that you know that have RPM and telehealth. Ask them how it's going. And then finally, I would say, to quote Nike, just do it. We have maybe it's my military background, it's ready, fire, aim. Nothing is irrevocable. If you try it, you're not stuck with it, okay? If you try it a certain way, you're not stuck with that. There's no upfront investments. Think of the move towards telehealth and the move towards RPM. It's a journey. It's not a single event, and you can make adjustments along the way. Okay, we have 6 or 7 minutes left, and I'll stay on as long as anybody wants. And so this is the time for questions. And I'm probably going to stop sharing my screen. You get to look at me. And then if you have any questions, please type them in. And this is where I would hum the Jeopardy theme song if I felt like it. My mom was on Jeopardy back in the 1960s before Alex Trebek. It was Art Fleming was the host back in the 60s. There's our trivia for the day. All right, I got to go click here and look at the questions. And so here's a question. How many devices are required or allowed? First of all, you have to have medically cleared FDA approved devices. You can have as many as you want. You don't want to have your poor RPM client using 17 devices, and you can bill for RPM with just one device. You don't have to have some certain number. Okay. Here's a question: what are the potential insurance issues? If you have regular malpractice insurance, then, and all you're doing is providing telehealth, then you're covered. So there's no new issues. You'll sign, if you're buying the equipment yourself, then you'll probably sign some agreement with the software company that is providing RPM that covers you for software issues. If you work with Blue Star, then your agreement with Blue Star covers all those things. So there's no new insurance burden, I guess, is what I'm saying. Okay, let me check on this question. How much can a practice make from RPM? It depends. First of all, we can, if we know your practice specifically, its location and the number of patients and things, we can run a complete detailed analysis of how much you might be able to generate in new revenues and in new profits from RPM. But I generally ask people to remember three numbers. The first number is $25 a month per patient enrolled will be the profit to a practice if the practice does nothing. If the practice just enrolls people in RPM and does nothing, farms all the work out to somebody else, then you'll probably make, $25 a month, order of magnitude, for doing nothing. If you do a little bit of telehealth with that, then think $60 per patient per month. And then if you're active in telehealth, quarterly engagements with patients and things like that, an annual wellness visit, then it can be $100 per patient per month. So it's really up to you. And frankly, if you want to make more money, you can do other things. You can do chronic condition management. There are other ways to generate more funds, but those are the numbers I ask people to remember: 25 for nothing, 60 for a reasonable amount of telehealth, and 100 if you're active in telehealth. Okay, let me see what other kind of Q&A I have here. Does a mobile phone work for RPM? Yes, it does. Okay, we typically use tablets. We think a tablet is more effective. You can do more things with a tablet. The tablet is HIPAA compliant and it's focused just on telehealth, but mobile phones can work, and some places only use mobile phones for telehealth. Okay, I'm looking at more questions. Is patient consent required? Yes. We have a one-page form that the patient has to sign that basically says, I understand what telehealth is. I understand what you're doing with RPM. I understand where the data is going. I understand my responsibilities for the system. Okay, I'm plowing through these questions. We got just a few more minutes and then we'll wrap it up. Is a pre-existing patient relationship required? Yes and no. You have to have a relationship with the provider, has to have a relationship with the patient to prescribe RPM. Does it have to have been for years? No, it has to have been for at least one event. So you can actually onboard a new patient, and at the end of that first E&M visit, if you determine that this patient has hypertension and would benefit from RPM, you can assign RPM at the end of that visit. Okay, I'm doing Q&A again. What's my obligation in upfront investment? There is no upfront investment for RPM, at least not with Blue Star. I can't speak for other companies, and we can talk about this more in more of a sales call. But there's no financial investment. You don't have to buy any equipment. You don't have to sign up for any software. You don't have to. There is no investment. Okay, and then and there's no obligation. If you start the program and you don't like it anymore, you can just quit, and we'll shut down the patients that you have going, and that'll be it. You're not obligated for anything. We find that that's just easier. We find that a lot of the doctors that we talk to are getting hit up for expensive pieces of equipment or expensive programs, and this is not one of them. Okay, I can do a couple more minutes here, and then I'll let you guys go. Does the patient have to be in a rural or underserved area for telehealth? A while ago, several years, but not too many, telehealth was reserved for underserved areas and rural areas. Not so today. RPM can be applied anywhere. You could be a doctor on 52nd Street in New York City, and you could have a patient on 54th Street in New York City, and you could treat that patient via telehealth and get reimbursed. Okay, looking for more questions here. Can we integrate with my existing EMR? The answer is yes. How much integration and the cost of that integration will depend on how much data you want to go from the RPM system into your EMR, what kind of EMR you have, the speed at which we want to do it. But the bottom line is, if you want your RPM effort to be integrated with your EMR, it can be. Questions? All right, this might be the last one because I don't see any more after this one. How long does it take to get going? We typically, again, this is Blue Star, so I can't speak for other RPM providers, but typically we feel that from the day the physician signs a one-page non-binding letter of intent to the day that we're shipping out RPM kits to their patients is typically about 4 weeks. We can do our end in 2 weeks. Some practices want 4 weeks, some want 6, some want 2, but think about it, a month from the day the doctor or the provider says, yes, let's do this. And then during those 4 weeks, we do all the nuts and bolts to make sure that all the T's are crossed and the I's are dotted to make sure that everything is ready to go so that within 4 weeks, we can be shipping out kits. Okay, so the takeaway, telehealth is here to stay. CMS is pushing the world in this direction. RPM is one of the things that CMS is incentivizing. It's good for the patient. It's good for the practice. It's quite doable. It's not rocket science. And I'm a nuclear engineer, and so I guess I can opine on rocket science. And if you want more information, we're happy to provide it. Get in touch with the person that invited you to this webinar, and we'll set up a call with me and with our staff, and we'll be happy to answer your questions. And we hope that this was at least slightly fruitful for you. If any of the things that I mentioned here you can't find yourself, please again send an email to the rep that introduced you to this webinar, and we'll make sure that you get the information that we talked about. Okay? All right. Thanks, gang. Have a good night. Bye.